Good morning, everyone, and welcome to the Protect Our Healthcare Coalition Policy Briefing and Town Hall Conversation. Our theme for this briefing is Making Progress in Healthcare Coverage and Care. My name is Wayona Nelson Davies, and I am the Executive Director of the Economic Progress Institute. For those who may not know, the Economic Progress Institute's mission is to advocate for policies that improve economic security and opportunity for Rhode Islanders. We do this work in a few ways. We use data-driven research and analysis. We advocate for and educate community leaders and policymakers about policies that will give more people the opportunity to prosper. And we lead and participate in coalition building. Protect Our Healthcare is one of those coalitions where we lead and collaborate with many other community partners. Protect Our Healthcare is a diverse group of leading Rhode Island nonprofits and community-based consumer groups with a goal to protect and promote quality, comprehensive, affordable healthcare for all. You can learn more about the coalition, our partners, and our policy recommendations on our website at www.protecthealthrr.org. And we can also put that link in the chat. The conversation we're about to have is a very important one. Since 2011, about a year after President Obama signed the Affordable Care Act into law, I spent most of my legal career prior to joining EPI, working with healthcare providers, medical students, and community-based organizations to address access to healthcare coverage and health disparities due to poverty, social and legal issues that lead to negative health outcomes. Those experiences solidified in me the understanding that equity, economic, and social well-being are directly linked to healthcare and vice versa. So I'm really excited about this conversation as we continue to connect some of those dots. I would now like to briefly introduce our presenters and speakers. We have Linda Katz, Chairperson of the Protect Our Healthcare Coalition and our very own Policy Director at the Economic Progress Institute. Seamus Durek, Staff Attorney at the Rhode Island Parents Information Network. Caitlin Rapp, Health Policy Analyst at Rhode Island Kids Count. Marjorie Waters, from Rhode Island Organizing Project and Voices for Better Health. Louisa DeNovis from SEIU 1199. Dr. Nitin Paul from Tunamis Health Center. Annie DeLoritu, Patient Advocate at Health Association of Rhode Island. Lori Marie Peixoto, Executive Director of Mental Health Association of Rhode Island. Thanks to our presenters and speakers for joining us today. Now I would like to give a quick overview of our agenda for the day. It will incorporate brief presentations about the benefits and limitations of the state and federal partnership in making progress in health coverage and care, and will include throughout a review of legislative proposals endorsed by the coalition that help us maximize the partnership. Our legislative proposals include safeguard access to meaningful coverage by codifying the Affordable Care Act consumer protections in state law, close gaps in Medicaid to improve access and equity, demonstrate care for our care economy, impacts health disparities, and make progress towards achieving parity in behavioral health. We'll close out the session with time for questions and dialogue. For those attending, please feel free to post questions in the chat and we will try to respond in real time if possible, or we will hold and post your questions to the panel during the Q&A session. And now, to get us started off, I would like to turn it over to Linda.
Thanks, Wayona. I'm going to share my screen. And Oop. I'm just looking to set it up as the slideshow. Okay. Hi, everybody. As I'm really happy to be here and happy to see so many friends of advocacy to promote better healthcare in our state. I'm going to do a little sort of Medicaid. It's not even a 101, it might be a 99, just talking about Medicaid in terms of populations and services that the program covers, because that directly links to the work that we're doing together through Protect Our Healthcare to close gaps in coverage and to look at access to meeting social determinants of health. So hopefully now okay, so just briefly, as I hope most people know, Medicaid provides Rhode Island with significant federal funds to provide healthcare and long-term care services to over 300,000 Rhode Islanders. And depending on the population that's being covered, we get different federal matching amounts. So for our regular Medicaid match, no state has lower than a 50% match from the feds. Rhode Island's currently at 61%. So for every dollar we spend, we basically get 61 cents back from the feds. For the CHIP population, which is pregnant women and some children in higher income groups, the match is close to 73%. And for the expansion population, which are the adults without kids who became eligible for the first time after the ACA was enacted, we get 90 cents on the dollar, and that's a rate that will stay fixed for forever. The other rates can change each year based on the formula that's used to determine the federal match rate. These rates include an additional 6.2%, not the 90%, but the CHIP and regular Medicaid includes a 6.2% additional match from the feds under the CARES Act that was enacted to encourage both to help states meet higher healthcare needs and costs, and also to encourage states to ensure that nobody lost coverage during the pandemic. So to qualify for this enhanced rate, the state cannot terminate coverage unless the beneficiary requests that their case be closed, they move out of state, or they pass away. And this continues until the end of the month in which the public health emergency ends. We're all waiting to hear when HHS tells us that the public health emergency ends, and then the state will start to do renewals, which is a separate topic that we can discuss sometime. Okay, so briefly, in Medicaid, there are both mandatory and optional populations and services. So mandatory, not surprisingly, in order to participate in Medicaid and get the matching funds, the state must cover certain individuals and provide certain services. And the state may also provide coverage for other populations and services. Those are called optional populations and services. So who are the mandatory populations? There are the groups of people, and they with income below certain amounts. So for children, the state must cover children through age 18 in families with income up to 138% of the poverty level, which is $31,781 for a family of 3. For pregnant, so that the income levels are the same for pregnant women, parents and caretakers, and children through age 18. These are the mandatory populations, the mandatory income limits. You can see the income amounts on the right-hand side. And then for seniors and people with disabilities who receive SSI, they are a mandatory population, and the SSI benefit level is only 61% of the poverty level. So that means the income limit for the mandatory elders and people with disabilities is only 61% of poverty. I wanted to add an additional population, which is the state must offer Medicare savings programs to low-income seniors and people with disabilities enrolled in Medicare. And that means that then the Medicaid program will pay for the Medicare premium, which is currently $170.10 a month for the lowest income folks would also cover out-of-pocket costs. And there's a resource limit of close to $8,000. So now you're about to learn some very exciting terms. QIMBY, or Qualified Medicare Beneficiaries, that's the lowest income folks. In Rhode Island, the income limit is 100% of the poverty level. And for those folks, the Medicaid program would pay for both Part A and Part B premiums, as well as out-of-pocket costs. And then a little bit higher up the income level, SLIMBs, or Specified Low-Income Medicare Beneficiaries, the Medicaid program will cover just the premium, the $170 a month. And then there's a group called Qualifying Individuals, or QIs, where the Part B premium is also covered. The income limit is a little bit higher, and it's a capped number of people who can participate. In Rhode Island, we've never hit that cap. The reason I'm showing this is, as you'll see, one of the key policy proposals from Voices for Better Health and RIOP is about increasing these income limits, and it's also a priority for Protect Our Healthcare. Okay, so those were the mandatory populations. Now we're going to talk about who may the state cover. What can the state do? So the state can cover individuals with income below 138% of poverty. That's the Medicaid expansion group. As many of you know, the hope with the ACA was that this population would also be a mandatory group, and there would be a sort of a floor of covering everybody except for elders and people with disabilities with income below 138% of poverty. Supreme Court said that the feds could not force the state to adopt this mandatory population, so it's been optional. Rhode Island adopted this population right out of the box. Slowly, other states have done that as well. Then the state can provide coverage to the categories of people that we saw on the first slide who are mandatory, who have higher income levels. So in Rhode Island, we don't just cover children up to 138% of poverty, we cover them up to 266%, which is $61,260 for a family of 3. For pregnant women, the income limit is 258% of poverty. As you see, $47,000 a year. And for seniors and people with disabilities, we're not at 61% of poverty, we're at 100% of poverty. Obviously, a lot of equity issues here for seniors and people with disabilities. Other optional populations include medically needy, who are people with income above the regular Medicaid limit, who, if they have high medical bills, can use those bills to spend down and become eligible on a 6-month basis. The Katie Beckett population, which are children with significant disabilities, are also an optional population. And then people who need Medicaid to cover long-term services and supports in the community or a nursing facility are an optional population. Rhode Island provides those services and covers those populations. I need to talk about the immigrant eligibility rules, because that, besides the financial eligibility, so income and resources, there are also rules about immigrants being eligible for coverage. So briefly, refugees, persons granted asylum, and certain other humanitarian groups are all going to be eligible for Medicaid if they meet the financial rules. All pregnant women are eligible for Medicaid, including those who are undocumented, and children who are lawfully present, which includes kids with a green card who are permanently in the country, are eligible without a wait, but also other lawful kids in other lawful statuses are also eligible. So for example, Liberians currently have deferred enforced departure. Those children will be eligible for Medicaid. People with temporary protected status as well. Those includes Haitians, for example. But for adults, it's only adults who are lawful permanent residents, which means they have a green card, and they are not eligible until they've been in status for 5 years. Now we're going to look briefly at mandatory services. So those services include hospital, doctors, lab and x-ray, family planning, home health services, nursing facility services for adults, and early periodic screening, diagnosis, and treatment for youth, should say under age 21. That's the EPSDT. It's not a separate program. It's a requirement that the states provide periodic screening for youth when there is a diagnosis, that then the young person is entitled to treatment for any diagnoses that are needs that are discovered during that screening period. So it provides a broad range of services for children. It is a reason that dental services are mandatory for kids, but they're not mandatory for adults. So optional services, everybody is always surprised that prescription drugs are optional services, but they are. But of course, most states will provide that service. Vision service, hearing aids, and rehab services are all optional services. There is one service for which the state may not receive federal cost sharing, and that is for abortion services. For our Protect Our Healthcare Policy platform, in promoting equity, we want to close gaps in Medicaid coverage and services. So we have the Cover All Kids bill, which is sponsored by Rep. Morales in the House and Senator Cano, which would provide coverage for undocumented children. We'll hear a little bit more about that soon. There is the second proposal is to expand postpartum Medicaid coverage from 60 days to 12 months for all women who give birth while enrolled in Medicaid. So that would mean that regardless of immigration status, 12 months of Medicaid coverage would be provided to all women. That bill is sponsored by Rep. Williams and Senator Goodwin. And the last is to cover abortion services so that we make sure that we have equity and access to healthcare services. And that those bills are sponsored by Rep. Kassar and Senator Oyer. Our next issue area, as Wayona outlined, is caring for our care economy. And there our proposals are to ensure that people who are caring for people are paid a fair and reasonable wage. And there is a commission that is proposed to be set up in bills by Senator DePalma and Rep. Casimiro that would look at what the state is paying providers across a range of human services programs to make sure that over time people are reimbursed at a fair wage. Of particular interest for Protect Our Healthcare is increasing wages for people who provide self-directed care. Those are independent providers and people who have personal choice. We're going to hear a little bit more about that from Luisa Dinoves in terms of the need to increase rates for people who provide independent care services. And the platform for Protect Our Healthcare also includes opposing cuts to what's called Perry Sullivan, which is a state law enacted 15 years ago that was sort of a way to try to make sure that Rhode Island balanced long-term care by reinvesting funds that were saved from a reduction in nursing home beds into home and community-based services. And what the governor has proposed this year is to meet the Perry Sullivan obligation of investments by using some enhanced funds that the federal government is giving to the state to expand home and community-based services. And we're very opposed to that cut, which would amount to about a $40 million cut in what otherwise would be available for home and community-based services in our state. In addition, you'll remember I talked about the Medicare savings programs. One of the proposals is to increase eligibility for the Medicare saving programs through bills submitted by Rep. Alzate and Senator Cano. And you can see here that we're proposing to allow the lowest income folks to have income below 185% of poverty participate in the Medicare savings programs, so that both their premiums, their coinsurance, and deductibles would be covered. Bump up the SLIMB eligibility from 120% of poverty to 200%, and for the capped program to increase from 135 to 225% of poverty. And the bills would also eliminate the asset test. We have the lowest income levels for these programs in New England, and there are a number of states that have also eliminated the asset test. And Marjorie will be talking a little bit more about that in a couple minutes. And lastly, in sort of the third category that we'll be talking about in this part of the presentation, is to address the social drivers of health, which we all know affect healthcare outcomes. So the proposal is to invest in affordable housing and also to expand food access through this retail SNAP incentive program, bills that were submitted by Rep. Barros and Senator Lawson. So I'm going to stop sharing my screen. And I'm going to welcome as our first speaker, Caitlin Rabb from Rhode Island Kids Count, to give us a little bit more information about the bills to expand, to cover all kids and to expand postpartum coverage for women for 12 months postpartum. So Caitlin, take it away.
Thank you so much, Linda. Thank you for inviting me here to talk about these two really important bills that would really help expand coverage for two different populations in the state of Rhode Island. So first, talking about Cover All Kids, as Linda said, this would restore right care health insurance to income eligible children who are undocumented immigrants. So a little bit of data, in 2019, 98.1% of Rhode Island children had health insurance coverage, which meant that only about 4,000 Rhode Island children were uninsured. And of these 4,000, 3,000 were income eligible for right care, but were not enrolled. So some of these children are income eligible and cannot be enrolled because of their immigration status. And Rhode Island previously provided access to right care to undocumented children until about 2007, when the funding was removed. So this legislation would restore right care coverage to income eligible kids regardless of their immigration status. And so a little bit of why this is important. So health insurance coverage really increases the likelihood that children will receive the needed preventative services and reduce costs later down the line. And if, for example, COVID has really shown us that the health of one person is important for the health of all. And so all children need coverage and access to healthcare for all of us to be healthy. They all go to school together. And so this is one step in the right direction to ensure that all kids in the state have health insurance coverage that they need. Next, moving on to the 12-month postpartum coverage. So this proposal would extend continuous coverage of full benefit medical assistance for 12 months from the current 60 days to all women who gave birth on Medicaid, regardless of their immigration status. And so right now, about 50% of Rhode Island births are paid for by Medicaid, but their Medicaid coverage extends only through 60 days postpartum. So for many women, including women with incomes between like 141, hoping I get the numbers right, and 258% of the federal poverty level are no longer eligible for Medicaid. And women who do not have qualified immigration status are not eligible either. So these two populations have to seek insurance elsewhere or risk becoming uninsured. And this is the postpartum period is a really critical time for people who give birth, women, and their children and infants as well. And so postpartum care includes recovery from childbirth, follow-up care, management of their conditions, both physically and talking about mental health care. With mental health care, about 1 in 5 Rhode Island mothers of infants report a depression diagnosis during and or after their most recent pregnancy. And this is more common in low-income women and women of color. So to help address the disparities that we're seeing in maternal mortality, this would be a great step towards improving maternal outcomes, especially among Black women and women of color. And again, consistent access to health insurance coverage will help reduce maternal mortality and improve maternal health and the health of their babies. And babies need healthy moms to promote consistent and nurturing care throughout the first year of life. So that's just a little bit about those two bills and legislation and the importance of that. And I will pass it back to you, Linda. Is that okay?
No, that's perfect. Thanks, Caitlin. And I just want to note that Brett Morales is with us. He's the sponsor of the Cover All Kids bill. He's been a real advocate for years in making sure that we have equal access to health insurance coverage for all our kids. And I also want to welcome Senator Valverde. So we're so glad to have you with us today. Next, we're going to focus a little bit more on caring for our care economy or caring for our caregivers. So I'm going to ask Marjorie Waters, who's going to speak about the Medicare Savings Program and also about improving pay for people who provide care to folks so that they can live at home. Marjorie?
Thank you. Can everybody hear me? This morning, I wanted to briefly touch on the Medicare Savings Plan and explain what that can mean to so many people in our community. I organize a lot of folks who just miss the mark for being Medicaid eligible. You know, as we know that the income level is very, very low. That doesn't mean that these people aren't struggling. You know, most of them live in subsidized housing, have very limited income, and the out-of-pocket costs can literally put them in the poorhouse, you know, really are devastating. With the increase in income on the Medicare Savings Plan, we offer eligibility to a population that desperately needs some relief. You know, I can't emphasize this enough. I've talked to people who are facing $10,000 medical bills, you know, $20,000 medical bills, simply because they don't, and we're talking about people who are usually have less than $20,000 a year of income, you know, so the bar is set far too low, in my opinion, to qualify for the Medicare Savings Program, and we need to raise the income levels and offer this life-saving program to more people, because if people know that they're going to have huge out-of-pocket expenses, they don't get the care. They opt out of surgeries, they opt out of medications. They just simply cannot afford it, and we need to change that dynamic. The second thing I'd like to talk about a little bit, which is pretty near and dear to my heart, is the failure of Rhode Island to keep its promise to rebalance LTSS options for home care. You know, as Linda mentioned, exempting the state from investing savings from reduction in nursing home beds into home and community-based services does not live up to the state's rebalancing commitment. A recent budget proposal to increase wages for home health aides, independent providers, and personal care aides to at least $15 an hour failed to make it into the governor's proposed 2023 budget. Rhode Island must increase its investments in home and community-based services to achieve that rebalancing of the long-term healthcare system. Rhode Island must provide more options for home and community-based care versus institutional care. We all know nursing homes care is more costly, not just financially for Rhode Island, but is costly to the dignity and independence of those who may spend the rest of their lives in a nursing home due to the critical shortage of home care workers. We have a direct care model called the independent provider that's languishing, not because it's not needed, but because the state has not provided the resources necessary to ensure its success. We need to expand the types of services that people need to live safely at home for as long as possible. Instead, we pay home health care workers so poorly that they're leaving the industry in droves. I'd like to talk a little bit about what is the cost of failure for inadequately funding home-based care and not providing workers with a living wage. We all have heard about the cost of paying better. What is the cost of not doing that? Right now, we have a system that is faltering and in danger of collapse, thus endangering the lives and well-being of those people who desperately need at-home care. And some of the issues that pop out of that, we have increased hospitalizations due to falls, burns, and other at-home accidents, more mental health issues, increased isolation, food insecurity, and higher risk of dementia due to lack of at-home care. Many families must forfeit their own financial stability to care for family members. We all know by now that the elderly languish without personal contact and care they need. At-home care provides not only help with the activities of daily living, but with the human contact, and facilitates a closer community ties that are really necessary to have for a quality of life, to have independence and dignity. Without this help at home, more people will end up exactly where they don't want to be, in a nursing facility. People want to stay in their homes and communities for as long as possible. We need to help them do that.
Thank you, Marjorie. I just want to note, if people are looking in the chat, I think we have, I do love China, but I didn't write that. So we're going to figure out what's going on here. I also just want to note that we had, I welcome Senator Valverde earlier, and I realized that we had the wrong bill number regarding the equity in abortion coverage, and it's actually Senator Valverde's bill in the Senate, and it is 2549. So my apologies, Senator Valverde, and thank you for promoting this really important bill. Okay, next we're going to hear from Luisa Dinovesh, who works with 1199 and has been helping to implement the independent provider program, which is, it shouldn't be so new anymore, but is a way to provide folks with being able to hire somebody who can provide them with care in their home. And Luisa will tell us a little bit more about that, and also why the program is so important. So Luisa, take it away.
Hi, everyone, and thank you for the opportunity. My name is Luisa Dinovesh, and I am a union organizer with SEIU 1199 New England. So for the past 18 months, I've been working towards building actually the Rhode Island home care workforce, recruiting both potential consumers and personal care aides for the independent provider program. The IP program, so it's a self-directed option for people who need care and physical assistance on activities of daily living, but who want to keep their independence and at the comfort of their homes. In September 2020, we started our home care Facebook page, the Rhode Island United for Home Care Independence, and we have been contacted by over 2,000 people. Also, with the advertising being done in different languages, we have recruited American, Spanish, Cape Verdean, and Portuguese-speaking individuals. My job is not only to recruit, but also to follow up. This follow up with both PCAs, consumers, and consumers, it's very important as it creates a trust relationship with the dyads. The consumers are grateful and joyous of having a loved one able to take care of them. The quality of care that one can have when it's your son, daughter, your granddaughter, a trusted friend, or any other loved one taking care of you allows a sense of dignity when you need home care. But they also tell me of the need of better wages and recognition for the home care providers. Why would someone work so hard, do such an honorable work, and yet no benefits, poverty wages, no security at all at the job? A substantial necessary raise would make all the difference. These home care providers are essential workers and provide a major impact on their patients' lives. It took me a while to get to this point, but today it is clear to me that the IP program is a big solution for our seniors and families in Rhode Island. Rhode Island is first in the country for population over 85. We are 7th for population over 65. Rhode Island is 41st in the country for Medicaid population accessing home care, and this is unacceptable. The need for home care is increasing as it is our aging population. Then why it is so hard and difficult to get help from the states? Just facts, over 1,500 residents died in nursing homes because of COVID. Had we a better home access, less would have died. It's urgent, urgent. We need to invest and expand access to home care. We also need a substantial investment in recruitment, retention, training, and professionalism within the workforce. But more than anything, I insist, we need to raise the wages for home care providers. How can they live with dignity with $13.82 an hour? How can I provide the care needed with such a low wage? Why do I need a second job in order to barely make meet ends? On a daily basis, I talk with people who'd rather take care of a loved one at home, but they can just not do it for financial reasons. Give the consumers the opportunity to stay at home with their family, within their communities, improving their quality of life and dignity. It's time to rebalance. We need a big investment in home care and community-based services to which everyone, given all the different languages and cultures and subgroups, groups could beneficiate. This is what consumers want. This is what families want, and our goal should be keeping people at home as long as possible for the brightest range of people and in every economic class. But for that, we need more support. Reforming Medicaid rate settings, improving the wage of workers, especially AIDS and community-based workers, will improve the lives of both patients and workers, but also their families. Thank you.
Thank you, Luisa. That was fantastic. And Marjorie as well. We will get there. I realized I couldn't see on my screen everybody was here. So I also want to welcome Rep. Kislak, who is an ardent supporter of all things progressive and all the healthcare work that is going on. I'm now pleased to introduce Dr. Nitin Paul, who is going to sort of bring the perspective of how important addressing needs other than direct healthcare is to ensuring that people have good health outcomes. And it's certainly a key equity issue in terms of addressing housing needs and food needs, et cetera. So Dr. Paul, take it away.
Hi, good afternoon, everyone. Can you all hear me okay? All right, great. Just wanted to also give a big shout out to the couple of people who've spoken already. I'm a primary care physician working up in Woonsocket, and I use, for my patients, we use LTSS and so many home health workers to keep our patients healthy. It's a vital service. So really, really, I just wanted to second what has been said so far. To speak more directly to just, I think the buzzword of social determinants of health has been tossed around now for a few years. The question always comes down to like, how do we actually make, turn that from a buzzword into an actual strategy? And I think part of that comes down to priority setting. And I guess I'll try to share just a couple of examples of my patient stories and, let that speak for itself. And through all of these stories, I often find myself kind of trying to put myself in their place and wondering how I would have kind of navigated that or how it would have been for me. And the one word that comes back to my mind is sheer panic. I mean, I'm not understating at all what so many of our patients go through. If any of us went through that, we would be in a state of fight or flight kind of panic mode. I have a mom and I take care of her 2 kids as well. The kids they're twins. They're about 5 years old now. And, they were living outside. They were luckily able to get a place in a family shelter so they could stay together. And it's been a year now. The mom is working on her own degree to get a higher paying job because the job that she had until then could not cover the rent, and which is why, they eventually were forced out. But the part that I kind of was really thinking about was the kids, right? Like they're 5 years old. And I keep thinking about, imagine if you had to go to school every day and keep coming back, not to your home, but to a shelter, and what that does to your psyche. Like how does that set you up for life, moving forward? And I think that's what we're talking about here. We're trying to prevent things. So many of my patients who are struggling with, access to food, housing, so many of them experience various forms of what we now know are trauma. And this kind of ends up kind of leading to survival mode behaviors, which help them get through that moment, but are not good, are not actually beneficial for their health in the long run. And so hopefully in the next, with a couple of patient stories, we can start to kind of pick that apart and try to understand how urgent some of these needs are and how much it comes back to only, policy level interventions can actually get at the root causes of this. There's nothing I can do in the office setting, the medical clinic setting, that'll actually address these root causes. Until then, these healthcare workers, home aid workers, we're all putting band-aids on the problem, but we need to get some of our basic needs met. And that's how I think about social determinants of health. So that being said, one of my patients, he has a history of substance use for many, many years. And when he came to me, he was still going through with it, still struggling with using substances and just struggling with addiction in general. We were eventually able to get him into a motel voucher. He then himself kind of set up so that he went to an inpatient rehab program, and he's come out of it and he's back in the motel and he's doing much better. And I was asking him, like, what is it? What's the difference, in these past few months? Why now? And he's like, this whole road to recovery, once you develop an addiction, right, it's a lifelong process to chart a new course back to finding yourself again. And he's like, that in itself is a tough enough thing to do, but it's something that he was driven to do. He's looking for a job, he's, doing all of that. But he's like, when I didn't have a home, when I was sleeping outside, there's just no way. Like any time I told myself, okay, this is going to be it. This is now, I'm not going to use this again. The cold would set in, the bones would start to really hurt and ache. And it's impossible, he said, to build when the foundation is not there to move forward from. There's another patient of mine. She's about 30, 32 years old. She had been on and off of living outside. Big part of this was she works minimum wage jobs. It's not been enough to get her own place. She was in a situation back at home with her family where she could not stay there for her own safety. And so she eventually moved out and was living wherever she could get a couch or a bed or surface to sleep on. And, you know, over time, especially when she was sleeping outside, she was telling me that at nighttime, it's so scary for her to be sleeping outside that she couldn't sleep. And if she stayed in one place too long, she felt she was too vulnerable to attack. And so she would walk around all night long. Maybe she'd get an hour of a nap in here and there until someone also, she heard some footsteps, and then she'd get up and walk again. She did this for night after night. And again, like that kind of trauma has long lasting consequences to all of these things. So eventually, you know, when I was seeing her, she was underweight, struggling with mental health challenges. Schizophrenia, we found, really starts to come out when you're faced with this kind of trauma. She was really struggling, but eventually, again, we worked, you know, we connected her with our social work teams and community health worker teams, and they were able to get her into a shelter. And when she transitioned to a motel voucher, she's been there for a while. And now, most recently, you know, she has finally, for the first time in a while, been able to keep a steady job for over a month. And more than that, it's just been incredible to see her transform, you know, as I was seeing her almost on a every 2-week basis. But then comes the second part of the problem, where she has this job now, but now she moved past, she was underweight, then there was a point where she was in the place where she should be with regards to her weight, and then she started moving to the overweight part. And that's part two, right? When it's not housing, it's something else. It can be food. In this case, with minimum wage, okay, now she can, at least with the motel voucher, she's able to at least stay sheltered. But still, the amount of money it takes to access to healthy foods is a whole different other question. So now she's going to more fast food restaurants or quick eats and things like that. And that starts developing other problems. I'm talking about her blood pressure starting to creep up. We're talking about her now being at risk for diabetes as her A1C levels move up. And so all of these things, food insecurity and housing insecurity, and so many other basic human needs, you can't just parcel them out, you know, piece by piece. They're all interacting, they're all interrelated. And I think that's a big part of what we're talking about today, whether it's, you know, expanding access to SNAP, or, you know, actually building affordable housing so that people, even on minimum wage, can afford it. So you got two options: either raise the minimum wage or really drastically lower rent. But again, those are the root causes that will actually get at the health challenges we're talking about. And the last thing I'll say is, at another patient of mine, also struggling with substance use at some point, has a good family network. Everyone in his family, though, is below poverty line. People who do have homes are not able to keep them there for zoning restrictions and things like that. And his cousin, he's called, you know, sometimes he calls his cousin, and on the visit, he's like, I wish I could add him, you know, to our, like, they have a separate garage place that they're not using. I wish I could, like, make that into a place where he could actually stay. I would then be able to look after him, make sure, you know, we do all these things. And that's what family is, right? Like, we try to support each other and things like that. But again, they can't do that because of the way that the zoning laws are where he lives at. And so all of those things to say that, you know, the nitty-gritty details matter, but the panic is real. I hope we all feel it. I hope we all know it. And, you know, all of the stuff that we're trying to push out with the policies and things like that, they're not just suggestions from my perspective. They're the yells and screams and shouts, because we're at that point, and it's been at that point for too long. So I'll leave it at that.
Nitin, thank you. That was amazing. And I know Brenda Clement is her heart is leaping for joy. Brenda's been a really important partner with us in the housing world. And hopefully during we'll have time at the end to talk more about many of these issues and to answer folks' questions. We can all take a deep breath. We're going to just sort of flip over to the other part of our presentation to be talking about the ACA and behavioral health parity issues as well. We all know that we just need to look at everything holistically, right? In terms of health, mental health, behavioral health, dental care, as well as the whole person. So I'm going to turn it over to Seamus Durak from Ripon, who's going to take over this section to give some information about the federal and state partnerships around ACA and behavioral health parity, and then introduce our great speakers. Thanks, everybody.
Great, and thanks for that, Linda. Thanks as well to Wayona, to the other speakers. Thanks to the members of the Assembly who are here today, and for all of your work that you're doing to advance this important work. My name is Seamus Durak. I am an attorney and health policy analyst with Ripon, the Rhode Island Parent Information Network. For those of you who might not know about our work, we are a nonprofit that serves folks across a wide variety of things. We assist families of children with special needs. We provide some care management services, but kind of most germane to my work and to the work here related with the Protect Our Healthcare Coalition, we operate a consumer health insurance assistance program for all Rhode Islanders. It's a live answer call center. Folks can call in with any sort of health insurance issues. And in our work providing that service to Rhode Islanders, we certainly see the whole spectrum of access challenges of folks that are eligible but just don't know about the programs that are out there, for folks that are not yet eligible for these programs that some of this legislation is working to advance. And then sometimes most crucially, folks that are just caught up in a complicated health insurance system that is not designed in a way that is user-friendly, that is accessible. And so we're able to reach that, but we also see the fact that there are many Rhode Islanders out there that are overwhelmed by this, that need concrete steps moving forward to make health insurance more useful and more accessible, and to protect the gains that we've had so far. So with that, I'm going to talk a little bit first about the Affordable Care Act and its impact here in Rhode Island, and a little bit then after that about behavioral health parity and what that means and what we can do in Rhode Island to improve access to behavioral health through both the enforcement of parity laws and through other actions that will make behavioral health services more accessible for Rhode Islanders. The Affordable Care Act, since it was passed at this point a decade plus ago, and since it was implemented, has had a significant impact in Rhode Island. I could spend an entire hour speaking about all of the things that it did, but I'll just do a quick overview here of some of the most important things in relation to our work. When the Affordable Care Act was passed, or before it was passed in 2010, Rhode Island had an uninsurance rate of 12.2%. More than 1 out of every 10 Rhode Islanders did not have health insurance. Now, only 3.1% of Rhode Islanders are uninsured. That's the third lowest uninsured rate in the country, but all across the country, uninsured rates have improved from the ACA, but thanks to Rhode Island's particularly effective implementation of the ACA's provisions, we've brought that down to about a quarter of what it was previously. Obviously, there's still work to be done, but a significant part of that is through the implementation of things that already exist. Now we just need to continue to move that forward with things like Cover All Kids, with things like 12-month postpartum to expand that coverage a bit more. 460,000 Rhode Islanders, almost half of Rhode Islanders, have something that would be considered a pre-existing condition before the ACA. Thanks to the ACA, those Rhode Islanders are guaranteed coverage. They can't be told by an insurer that they are not insurable, that they are not entitled to coverage because of a pre-existing medical condition. They don't have higher premiums. They don't have waiting periods for coverage. They're just entitled to healthcare coverage, which they particularly need. At least 82,200 Rhode Islanders currently are enrolled in Medicaid due to Medicaid expansion. That's a huge increase in the Medicaid population in Rhode Island, bringing an entirely new group of very medically needy, frequently folks into healthcare coverage that weren't entitled to just about anything before. They couldn't afford coverage on the market, but they weren't entitled to Medicaid. And just over 30,000 Rhode Islanders receive coverage through HealthSource Rhode Island, the Rhode Island-based healthcare exchange that was established by the ACA. And now these are paid plans, but almost 80% of these folks have what are called advanced premium tax credits, the federal subsidies that make coverage a little bit more affordable. And these plans can be expensive, but on average, monthly APTCs average $355 a month, leaving the average consumer paying $120 a month. So at this point, the federal government, through tax subsidies, is paying about 3/4 of the cost of coverage for folks on the exchange, compared to the enrollee paying about 1/4 of that. There's no more annual or lifetime caps on coverage. That's something that's been a significant issue in the past. If you had a serious medical need, or you had an accident or a treatment for cancer or something like that, you would exhaust potentially your annual cap on coverage, but even more so your lifetime cap, and you would essentially no longer be eligible for any insurance payment for any condition, whether related to what was so costly or anything else in the future. Those have gone away now. There are no more skimpy plans that omit important necessary services. You can't sell a plan through the exchange that only covers some things but doesn't cover other important services. There are essential health benefits that every plan needs to cover. And it guarantees access to important preventive services without out-of-pocket costs. Things like routine screenings for colon cancer, contraceptives, a variety of services are available for free without any out-of-pocket costs, thanks to the Affordable Care Act. And that's just from the original Affordable Care Act that was passed quite some time ago. The American Rescue Plan that was passed during the COVID pandemic expanded some of that. Originally, tax credits were capped at 4 times the federal poverty level. At this point, no American will pay more than 8.5% of their income for the benchmark plan. That means that entirely new groups of moderate to like lower to moderate income folks are now eligible for tax credits that were not eligible before. That included 6,100 in Rhode Island, and the 24,000 plus Rhode Islanders who were already receiving tax credits are now eligible for even cheaper coverage. So their tax credits have gone up. That also includes folks whose income is below 1.5 times the federal poverty level. Folks that are just above the Medicaid income limit, don't have a lot of money to spend on medical expenses, are now eligible for plans that cost them $0 a month in premiums. These are 2 of the important aspects of the American Rescue Plan. There's more to it than that, but out of brevity, I'll leave it there. But the ACA remains under threat. Even after Supreme Court case after Supreme Court case where the ACA is upheld, there are still new threats constantly coming up. There's a challenge currently to the preventive services mandate that's winding its way through the courts. And I anticipate we'll continue to see this happening on and on into the future. The current administration is no longer taking an aggressive stance to deinstitutionalize the ACA, but the previous administration had that as a crux of its administration, and we could absolutely see that again in the future in an administration that would not be supportive. And there are certain things that have to be done at the federal level that if they're going to continue. Among those are the extension of advanced premium tax credits to people above 400% of the federal poverty line, and the additional tax credits available to others. These are things that need to be done federally. Rhode Island can't force, obviously, the federal government to extend that, though we can certainly ask our delegation to engage in those efforts. But there are plenty of other things, other aspects of the ACA that are really important that we can codify in state law that will help protect Rhode Islanders if anything were to happen down the road. For example, last year, the General Assembly passed House Bill 5763 prohibiting gender rating. And this year, there have been reintroduced bills by Representatives Kassar, Speakman, and Kislak, as well as by Senator Miller on the Senate side, to enact some remaining important protections from the Affordable Care Act into state law. These include the annual and lifetime caps that I was talking about, the no-cost preventive services, essential health benefits, ensuring that every plan has to cover important healthcare services in a way that all plans will cover those same services, and the guaranteed access to coverage to make sure that folks with pre-existing conditions are not told that they cannot have access to coverage. With that, I'll turn it over to Andy DiLoretto to speak a little bit about the impact of some of this.
Seamus, thank you. Appreciate that. Hello, everyone. It's nice to be with you all today for this policy briefing. Again, my name is Andy DiLoretto. I'm from Westerly. I'm a volunteer for the American Heart Association, where it is an honor to serve on the Rhode Island Advocacy Committee. Just a little background with me on my introduction to medical care beyond the normal annual physical. That began in college when I was diagnosed with a autoimmune disorder, and that really kind of set me on a path to regular doctor visits and prescription medications that really continue on to today. In 2006, I was diagnosed with heart valve disease and found myself in open heart surgery just 2 years after that. Following that heart surgery, I inexplicably suffered 2 strokes, one in 2009 and then the second one in 2011. The treatment and testing to find the reasons for all of this was endless and no doubt costly, including that private jet flight home from Rome where I suffered my second stroke. All that said, I mean, it sounds gloom and doom for me, but all that said, for 55, I live a fairly healthy lifestyle, but I do spend a great deal of time with doctors, medical appointments, prescription medications, et cetera, more than I ever could have imagined, at this point. But ironically, I come to you today, with, as someone filled with a lot of gratitude, immeasurable gratitude. I virtually have no restrictions, and I do have access to quality medical care and coverage. Through my advocacy work with the Heart Association, I've met so many Rhode Islanders who are fellow stroke survivors, fellow heart attack survivors, and congenital heart conditions survivors, and then just those with numerous other chronic medical issues. And I speak on behalf of all of them when I say that access to quality coverage and affordable health care is a matter of life and death for us. Prior to the Affordable Care Act, it was common for people to come up against coverage caps or conditions that were not covered. That meant people went without care or they went into medical debt. And we heard some of the comments earlier today. And, we just, sometimes that debt, and I've heard of personal stories where the debt was mountainous. And we certainly just can't allow that to happen again. It is, from our opinion, it's imperative that the General Assembly takes steps to safeguard the Affordable Care Act, in consumer and patient protections in state law. And these include the following 4, and Seamus had mentioned a couple of these already. Protecting Rhode Islanders with pre-existing conditions by guaranteeing the issuance and renewal of insurance policies so that patients cannot be denied coverage. Requiring that the plans cover the 10 essential health benefits. Prohibiting cost sharing such as copays and other out-of-pocket costs for preventive care. And then lastly, prohibiting annual and lifetime limits on coverage for essential benefits. It is really time for the legislation to get this legislation to the governor's desk. It is vital for Rhode Islanders like me. So on behalf of all of the patients that I'm here representing, I'd like to thank each of you for your time today. And Seamus, I'm going to pass it back to you.
Great, thanks for that, Andy. And at this point, I'm going to shift gears a little bit and talk a bit about behavioral health parity and what that means, what the laws look like currently, and what we can be doing to strengthen what is clearly a behavioral health access system that is not providing the services that Rhode Islanders truly need. So there are existing laws that say that behavioral health, mental health, and substance use disorder services must be covered at parity with medical and surgical services. There's a federal law that applies somewhat broadly, and then there's a state law that applies specifically to state-based health insurance plans. I know that this is something that we've discussed previously in our briefing last year, but obviously health insurance is complicated, and the health insurance coverage system is quite broad, such that there are some plans that state law can regulate, and there's some plans that state law cannot regulate. For example, Medicare is actually not covered by either parity law, but Medicaid is covered by both. In general, fully insured plans, those are frequently plans that people enroll in through smaller employers or through the individual market by buying them through HealthSource Rhode Island or directly. Those are going to be governed by state law as well as federal law, but large employer plans, self-insured plans are generally only covered by federal law. That being said, the parity laws apply then broadly to folks through receiving coverage through just about any form of health insurance except for Medicare. That being said, despite the existence of these laws, consumers are still clearly struggling to access behavioral health services. That's something that is not news to anyone, I don't think. But really the question is why, and why have these laws not helped resolve that? So, and some of that comes down to how parity is defined, and then some of it is how those laws have been enforced. Now, what parity is does not necessarily mean that every behavioral health service has to be covered. What it means is that the requirements around delivering mental health and substance use disorder services cannot be more strict than those same requirements are when they're applied to medical surgical services. That means you can't have a different separate deductible for your behavioral health services. You can't have higher copays to go see a behavioral health specialist than you would to see a medical surgical specialist. You can't have treatment limits that are higher for behavioral, or lower, I guess, for behavioral health than they are for medical surgical. You can't have a plan that says you're entitled to 30 physical therapy visits a year, but only 20 behavioral health therapy visits a year. And then the most complicated one is what's called NQTLs, or non-quantitative treatment limits. This is a really wide basket of things, and this is really where parity enforcement is taking place now. It's the complicated how the insurance company actually administers their plan sort of thing. These are things like the medical necessity guidelines they use to say whether or not a service is actually necessary for you. They can't, as a rule, have medical necessity guidelines that are stricter or more strictly applied to behavioral health than they are to medical surgical. And then one really important one is they call them the network adequacy standards. These are the ways that a health insurance plan builds their health insurance network. These include a lot of different things. They can't just have a policy of saying no to any new behavioral health specialist when they're trying to bring in as many new medical surgical specialists as they can. But really importantly, it includes reimbursement rates. What it means and what is necessary under parity laws is that reimbursement rates cannot be set in a way that creates a less adequate network on the behavioral health side than it does on the medical surgical side. If rates are too low for behavioral health services, a provider network is going to be simply inadequate. Either it's just not going to have enough providers in it, or all the providers that are there are going to be fully booked and you're going to have long wait lists for anyone to see a therapist or a specialist that they need. Because of that, an increase in reimbursement rates needs to be a significant focus of parity enforcement, because we are seeing that happen. We are seeing provider networks that are just wholly inadequate in both the Medicaid and the commercial market. Sometimes particularly egregiously in the Medicaid market, but it's not specific to that market at all. And so what we need is for increased enforcement of the parity laws. And there are kind of two ways that, that are being advocated right now by the coalition for how to address this that I'm going to talk about. And then I'm going to turn it over to Lori Marie to talk a little bit more detail. One is Senate Bill 2471 and House Bill 7864, which would require increased reimbursement rates in outpatient behavioral health treatment, just to start pushing those rates up. And then separately is increased funding to the regulators in this sphere, who are EOHHS for Medicaid plans and OHIC for commercial plans, to really take a deeper dive into behavioral health reimbursement rates. As some of you may know, OHIC had a couple of years ago concluded the process of market conduct exams on the insurers in Rhode Island, and found significant faults across the board in their implementation of the parity law. But because of the need for additional resources to take a deep dive into reimbursement rates were not included in that market conduct exam. And we are encouraging that funding be provided, that such an investigation could be done in the future. With that, I'll turn things over to Lori Marie to talk a little bit more about our advocacy actions here.
Thank you, Seamus, and thank you everyone for all the great information and for sharing your stories. As Seamus mentioned, we have what's called the Rhode Island Mental Health Parity Initiative. And so I'll talk about one of our most important policy priorities. For those of you who don't know me, I'm the Executive Director of the Mental Health Association of Rhode Island. And I approach this work as someone with lived experience. And I can tell you that last year, when the pandemic was at its peak, I had to return to antidepressants, and I had to wait 5 or 6 months on a wait list to see an outpatient psychiatrist. I got the prescription from my primary care doc because I just couldn't wait that long. But I can tell you now that I have a wonderful psychiatrist, I can really see that he has a deeper understanding of medications and how to work with me and my particular biology. So there really is a difference when one is working with an expert, a specialist. So one solution that Seamus just touched on, we are tackling the inadequacy of our behavioral health provider network in Rhode Island. And as he mentioned, one way to do that is to raise behavioral health provider reimbursement rates in Medicaid and also in commercial insurance. And so we have two pieces of legislation, 2471 sponsored by Senator Miller and 7861 sponsored by Representative Tanzi. And these bills raise commercial and Medicaid reimbursement rates paid to outpatient behavioral health providers. The bills require that the lowest paying insurers and Medicaid increase their rates to a median standard. We have submitted proposed amendments to the sponsors that would actually require commercial in-network outpatient behavioral health care services to be reimbursed no less than the rate of inflation. And we're measuring the rate of inflation by using the Consumer Price Index. And so this would go into effect January 24th and increase annually thereafter through 2028. We've proposed these amendments. We also proposed perhaps removing the Medicaid part of our bill because it's potentially addressed in other pieces of legislation. One of our sponsors would like us to keep Medicaid in. And then if we absolutely have to take Medicaid out, if we have the opportunity to negotiate our legislation, then that would be something we would consider at that time. But really the gist is just raising reimbursement rates for providers to attract professionals into the field and retain the professionals that we do have in Rhode Island, so that patients like me don't go on a wait list, don't have to pay out of pocket for an out-of-network provider, or don't have to skip treatment altogether. Because when we are delayed in our treatment or neglect to have treatment, our conditions worsen, and that increases the utilization rates of very restrictive and expensive levels of care, like emergency departments, inpatient hospitalization, residential treatment centers, and so on. So it improves patient outcomes and it makes good fiscal sense as well. Thank you very much. Happy to answer any questions.
Karen, you're on
Lori.
mute.
Thank you, Lori and Seamus. That sort of concludes our presentation and speaker part of the program. I'd love to open this to more dialogue. If there are questions that people have of any of our speakers or comments that people would like to contribute to the conversation. One of the things, I'm Karen Malcolm, I am the coordinator for Protect Our Healthcare Coalition. I want to thank everybody who's spoken today and who's in attendance. Apologize for getting hacked earlier. I think we resolved the problem fairly quickly, I hope. You'd think people would have better things to do. I think one of the highlights of today's presentation is how we need to approach systems change in healthcare access and delivery in a holistic way. That if we really want to improve outcomes and access, it depends on implementing a range of policy proposals that we can do here at the state level, despite what might be happening at the federal level. And I hope that came across. I see that Tanya has her hand up, so I'm gonna turn it over to her. Tanya, you're muted.
Sorry about that. I was trying to get to the right screen. Hi, everyone. I really just wanted to quickly jump in and say thank you to all for such excellent presentations. I know the Coalition for Children and Families relies on the expertise of the table that's set by Protect Our Healthcare Coalition to understand the incredible details and nuance of all of the healthcare programs that really underlie the kinds of services we're trying to provide for children, youth, and families, and just wanted to congratulate you on a great presentation. Thank you.
Thank you, Tanya. I think, Dr. Paul in his comments said earlier that it's impossible to build, and he was speaking in regards to individual patients, how it's impossible to build when the foundation isn't there. And I think that's true of us as individuals if we're seeking to build health and well-being, both physical and financial for our families, but that's true for us as a state as well, that when we have a healthy population and we improve on some of our very poor, currently poor health outcomes, that we can collectively move forward as a state in all of the other realms that we're talking, that people think about in terms of like our economy and the quality of life that people are afforded when they live here. And so I think that's something I appreciate about working with the coalition is this range of policy proposals that get outlined on an annual basis. Marjorie's hand is up.
I just want to thank Dr. Paul for his perspective. I live in Woonsocket, so I see I observe every day the need that is here. It is so great. From literally the newborn baby to the 90-year-old, and we are like, as he, talking about the social determinants of health, we have to take that to heart, and housing, I want to thank you once again for mentioning housing. It's a problem, whether it's children and families or even with elderly adults who may have mental health issues, hoarding issues, all those that can cause them to become unhoused. I recently read an article where this is a growing phenomena across the country. Elderly are homeless due to finances, age, illness, and it's an increasing problem. And we have to get together, I think, as a society and say, we are not going to allow this. We're not going to allow children and seniors to be on the streets because there's no place for them to go. So thank you once again for your comment. It really hit home for me. Thank you.
Thank you, Marjorie. Rep Morales is here, and Rep Kislak, as well as Senator Valverde. And the three of them have sponsored some of this very important legislation. I'd like to invite them, if you would like to comment on your legislation and your commitment to that legislation. So Rep Morales, I see that you just opened up your screen.
Yeah, thank you so much, Karen. And first and foremost, I just want to thank you all again so much for your tireless advocacy on these issues as it relates to ensuring that, as we know, healthcare is a human right, but it is time that we apply it through policy. And that looks like expanding some of these crucial programs. And I'm very proud to be the lead sponsor on the House side for the Cover All Kids Initiative, House Bill 7484. And I'm really proud of the work that we've been able to do to ensure that's part of the governor's budget. And for context, we had our committee hearing back in House Finance in February, and it went very well. It was a very special hearing because we had an opportunity to allow our lawmakers to hear from people from all walks of life who would benefit from this legislation, from medical professionals to educators to local officials to, most importantly, our working families who unfortunately have children who cannot access healthcare simply due to their immigration status, something that they have absolutely no control over. So now is the time that we restore this coverage, because for over a decade, Rhode Island was one of the only states that provided this Medicaid expansion. And now is the time that we revisit, and most importantly, ensure that we expand that coverage for all children. So with that being said, I'm feeling very good heading into May, heading into June, as we start to finalize the budget. That Cover All Kids is going to remain in the budget, but most importantly, be codified in law through the passage of both the House and the Senate bills. And this has only been possible because of all the grassroots work that you have all been doing. So I want to thank again the Protect Our Healthcare Coalition as it relates to this bill, and look forward to seeing it at the finish line with you all.
Thanks, Rep Morales. I want to turn it over to Rep Kislak. And, she has been a strong advocate in the House on the codifying of the ACA provisions in state law. So Rep Kislak.
Thank you. I am really committed to making sure that we in Rhode Island do everything we can do to codify the Affordable Care Act here in Rhode Island, because we know and we see what's happening at the national level, and there are going to be continued attacks on our access to healthcare through the Affordable Care Act. And there are a suite of bills that would do this. And the one that I am the chief sponsor on is also the one that is most important to me, but they are all very, very important. And that's the one that would bar lifetime and annual limits on coverage. And when I was a lawyer at Legal Services, I had a client whose family called me because they needed or wanted to file bankruptcy. And they wanted to file bankruptcy because it turned out it was a coding error, and they had run out of private health insurance by the time their kid was 2 years old. A $2 million baby, very, very, very sick, needed a lot of very intense care, had no more private insurance. and their insurer wasn't coding something properly, and so Medicaid wouldn't cover their medications. So like we fixed that case, but the underlying issue that families and people can pay insurance premiums for years and years, 20 years, lifetimes, and then suddenly a very expensive healthcare situation occurs and you lose your private health insurance. And I am grateful to the Affordable Care Act to stopping that from happening, and hope that we can guarantee that to happen here. And while I have the floor, people were talking about so many important things, and I just want to add to our list of bills to think about in terms of behavioral health parity and access, that there's another really important bill that one of my students brought to my attention, which is, and I am now a proud co-sponsor, which is the bill that would allow interstate licensing of psychologists. It's called the PsyPact bill, and I consider it another must-pass piece of legislation, along with a lot of the things folks here spoke about today. So thank you all very much for everything you do. It's really fun to be here.
Thanks, Rep. Kislak. I see that Bernie Boudreau has his hand up.
Just a quick thank you to everybody. And as we all know, we can be as rational as ever and not affect the emotion. I think the stories and the personal accounts that I heard are really a huge motivator. We have the data, we know why this is all important objectively, but unless we have stories that can be forthcoming of real situations, we won't move the hearts of not just the legislature and the governor, but people generally. So just a plea for more stories.
Yeah. Thanks, Bernie. That's true. I think, we're past all of the pieces of legislation presented today have the data to support the rationale for passage and implementation. I think we need to move people. We need to move members of the assembly who aren't here today with those important stories. The video of this presentation will be shared via email with the full membership of the assembly. And I encourage those of you here today, I'll be sharing that video link. Please share it with others. It's not too late for people to hear what we've talked about today. I want to give Senator Valverde a chance to speak. I see she's on. She may not be available to speak, but I'll give her a moment. And if not, we're getting close to the end time here. We want to be sure to end on time, because I know how busy everybody is. So I'm going to turn it back to Linda to close it out with thanks. And a call to action. Please act. Share the video, share the information, testify on these bills, talk to other members of the assembly about these bills. A full list of the policy recommendations will be forwarded to you all as follow-up to this. Linda.
Thanks, Karen. And I want to first say a big thank you to Karen, who really was the person who organized all of the pieces of this presentation. So thank you, Karen. And, all of the speakers telling their stories were truly amazing. And that is what, I think keeps us all going as well, and is information that we need to share with the policymakers, because we know it, our hearts are there. We need to move them. The call to action, I want to say thank you to all of the speakers. Each one of you were remarkable in terms of, just putting a face and some passion behind sort of the dry information that Seamus and I both shared. So I hope we will all move forward together to try to see passage of all of the bills that we've talked about today. And, thank you all for your engagement with the Protect Our Healthcare Coalition and for all the work that you do as individuals and organizations outside of Protect Our Healthcare. So onward to victory for all of us. And thanks again.
Thank you, Linda. Thank you, everybody, and see you all soon, I hope.